Welcome to Differential Discussions. I'm Melissa,
I'm Dave.
and we're back with another theory podcast.
Woo! Yeah, so we started talking about coag and um, talked about vasculature. We talked about platelets. And we're still talking about platelets, I guess.
Yeah, we didn't finish normal platelets yet.
Yeah, they're really complicated.
They
In a
are.
good
I
way.
think we're going to really start hitting the complicated soon.
I know. And this is a tough area, right? Because the theory gets really dense and um yeah, I mean, I think the finer the detail you go into too, the more difficult to kind of keep things kind of like straight and but yeah. So we had talked about the granulations of our platelets.
Mm-hmm.
Um and so where are we heading next?
Well, I think next we're going to hit my fave.
So Melissa has a unhealthy obsession with von Willebrand's factor.
I
So,
do.
um, so we're going to talk about von Willis. Really important molecule, right? Physiologically, if you don't have it, we have a lot of like bleeding tendencies and stuff, right? So how do we start talking about von Willebrand's? What's the best
Well,
way?
I guess let's start with basics, right?
Yeah.
It's where it's stored, where it's made, where it's stored.
Yep.
So it's synthesized in our endothelial cells and our megakaryocytes, and
Okay.
then it's stored in either the Weevil Palade bodies of the endothelial cells or the alpha granules of the platelets.
Isn't Weeble play bodies like fun to say?
Mm. Fun fact, it seems like they're made specifically for the packaging of von Willebrand's factor. And when you can't package and make it appropriately, the Weevil Palade bodies are not quite as nice and as they should be.
That's interesting. So
Yeah.
it's almost like it's a core component. Like it's the storage and it's a piece of that storage, huh? That's what that would imply. That's
Yeah, there can be other things in there too, but they're really made because of Von Willy.
fun, Willie. Cool.
Yeah,
Cool.
and so just so everybody knows, when we talk about von Willebrand's factor, we usually call it Von Willy.
Yeah. So
Yeah.
I do those things without noticing.
Mhm.
You'll see it I'll be teaching and then they'll be like, well, I
Yeah.
have some kind of med lab slang or
I'm,
coag.
I'm I'm rubbing off on you.
Yeah, I know.
You're getting
Yeah.
my coag slang.
In a lot of ways. So it's fascinating, right? So this is a really important molecule for platelet function. So it's interesting that there's this evolutionary, where the platelet has von Wille, it kind of carries some von Wille along with it, right? That makes sense.
Yeah. So we measure von Willy. We'll talk about levels in a few minutes. But really, when you're talking about circulating von Willy, that comes from the Weevil Palade bodies.
And I
And when we're talking about von Willebrand's factor, acting at the site of injury, that's really coming from the platelet alpha granules.
mm-hmm.
So I think the other thing that's interesting about von Willebrand's factor, and this will play more of a role when you get into like the weeds of figuring out which von Willebrand's disease it is, but von Willy, it's a really, really, really big molecule. And I could go into like packaging and the Golgi because it's really cool, but I will digress and won't go into that. But when you think about how large of a molecule it is, it actually has a propeptide that's not it's cleaved from it, so it's no longer attached to it, but it's stored with it, and so they're still together in the storage units, so the Weevil Palade bodies and the alpha granules. And when they're released, the pro von Willebrand's factor, the propeptide, is also released. But we don't really understand its function or if it has function or what it is, other than it has a role during the creation and packaging of von Willebrand's. But you will find von Willebrand's propeptide in circulation because it's released at the same time. So you may hear von Willebrand's propeptide, and that's basically what it is. It's the propeptide piece that's cleaved off of the von Willebrand's factor, but is still necessary for it to be folded and packaged in the Golgi and then packaged into the storage units before it's released.
This propeptide, so that would be found in both von Wille from endothelium and from the alpha granule. Okay.
Mm-hmm. Yep.
So we know where it comes from, where it's stored. So can we start talking about function, you think?
Yep.
So yeah, so when in my mind, the first thing I think of with von Willebrand's factor is facilitating that collagen platelet adhesion, right?
Mm-hmm.
And more specifically in those high kind of stress areas, right?
Wherever
So
there's high shear flow.
yes, high shear. That's the much more appropriate term, right? So blood flow is moving really, really fast.
Yep.
I don't think people really appreciate how fast it's moving. So if you imagine, you're on the highway going 100 miles an hour and you try to reach out and grab like a sign or something, right? You're going to have a difficulty. And von Willebrand factor kind of facilitates that that better for platelets, right?
Yep.
And then what else does it do?
It carries factor VIII.
So this is an underappreciated function of von Willebrand's factor. And so what happens when we don't have that, right? Maybe I'm digressing a little bit, but I think it's important, right?
It
If
is.
we had a deficiency in von Willebrand factor, that doesn't necessarily translate to a deficiency in factor VIII, but it does. So von Willebrand factor actually acts as like a stabilizing kind of carrier, right? So in the absence of von Willebrand factor, factor VIII will degrade rapidly. So
Yes.
that'll be helpful too, right? For von Willebrand's diseases and the different types of.
Yeah.
So
Yeah,
yeah.
functionally, if they're together, they won't dissociate until it's time to activate factor VIII and factor VIII to do its thing, because that's when you want factor VIII to be available on its own. But normally, it has to be factor VIII has to be carried by von Wille, otherwise it'll be destroyed. And then it looks like you lack factor VIII, but it's really you lack von Wille.
Which is fascinating. When you start digging into von Willebrand's disease and that particular phenotype. But yeah, anyway, I'm going in the weeds, but those are the fun things to kind of learn about. So like functionally, does that kind of cover the normal physiology of our von Willebrand's factor?
The important things, it can also aid in aggregation because it shares the RGD domain that fibrinogen does, but really the major functionalities are carrying factor VIII and mediating subendothelial platelet collagen binding with platelets.
So that's important too, right? So a student too might not appreciate the difference between adhering to collagen and aggregation, because those are very different, right?
We'll get there.
Yeah.
We're going to review that later on in here. We will talk about the difference.
We'll put a pin in that
Yeah.
one.
Yeah.
Sounds good.
Yeah.
So now we can kind of talk about the molecule structurally a little bit.
Sure.
I think. Okay. So a lot of different domains. We talked about it being such a big molecule. So is it fair to call these like receptors, or how would you describe the? Yeah.
Yeah, I think that's fair.
Yeah.
Basically, von Wille is a huge molecule, humongous. And when it's secreted from its storage units, usually ADAMTS13, which is its regulatory enzyme that breaks it down, is sitting there waiting, attached to a cellular adhesion molecule. This way, it can kind of cleave von Willebrand's factor from its ultra large form, which is what we usually call it when it's secreted, ultra large von Wille, into its high molecular weight, intermediate molecular weight, and low molecular weight forms. Why? Because von Wille is so big that if you secrete ultra large, it causes problems. So you really want von Wille to be in these different molecular weights. The nice thing is we can measure the molecular weights and see how much of each is present. And then, of course, your larger pieces of von Wille have greater functionality than your small pieces, although the small pieces still do have some functionality.
Mm-hmm. It's almost like it's bigger, so there's more receptors, right? So there's more opportunities for the physiological function. Yeah.
Yeah, and I think the larger pieces, if you think about the role, and I think we're going to talk about this more with coag when we talk about thrombin, but if you have to have a certain size molecule for certain functions.
Mm-hmm.
So certain functions are better performed by larger molecules compared to smaller.
That's a very interesting way to think about that.
So von Wille can, right? We just discussed how it has to bind factor VIII. So it
Yep.
has to have a factor VIII binding site.
Makes sense, right?
We
uh,
discussed how it mediates subendothelial collagen binding with platelets. So it has to have platelet receptors then and collagen receptors.
yep.
It
Yep.
has to be able to bind to collagen and it has to be able to bind to platelets. So for mediating that adherence, you have to have a receptor on the platelet surface that can bind to von Wille.
Mm-hmm.
And so the von Wille will have a receptor that can bind onto platelet receptor 1B95,
Right.
glycoprotein 1B95.
Right.
Okay. The other thing that I mentioned that it can do is aggregation. So it has to have another receptor for another platelet receptor so that it can bind onto glycoprotein 2B3A to aid in aggregation.
And
So
that makes sense, right? Because 2B3A is our platelet to platelet, sort of platelet to platelet, right? There's a fibrinogen sandwich going on there, but that's how our platelets are interacting with one another. So for it to do the aggregation component, it needs that that kind of interaction. So we got what the 1B95 receptor,
yep,
right? We have a 2B3A receptor.
yep.
Then we have a collagen receptor and factor VIII. I can't forget about factor VIII, right?
Yep.
So those are the major functional kind of pieces to it, right? And there's probably a lot more that we don't quite.
There's more, but then you're getting into the weeds,
Yeah.
right? And
Yeah.
we're not going quite that far into the weeds.
Now we're gonna keep it at a Dave level.
I'm gonna drag you down to a Melissa level on occasion.
Cool.
Listen, my husband would be proud. I didn't talk about the Golgi apparatus. He
Don't get
gets
me
so annoyed
started on
when I'm like,
Golgies.
let's talk about the Golgi. And he's like, no.
Yeah, like Golgi, like the only thing I think of is like morphological features and staining, and what is it? They package proteins or something there. I don't
They
know.
do. Yeah. Fun fact. All right, I'm gonna talk about the
Oh
Golgi
no,
first.
I did it. I
You
did
brought
it.
me to it, Dave. So yes, they package proteins and like they'll help kind of manipulate the protein so that it gets into its proper structure. The beginning, it gets more acidic as you go. So less work is done as you go. More work is done in the beginning of the Golgi apparatus than the end because the end it's too acidic and you're just getting ready to package it and get rid of it.
Mm.
Not von Wille.
Hmm.
A lot of the work is actually done in the acidic end of the Golgi apparatus because of the propeptide.
Okay.
It
So
helps in the
this is
packaging.
where, yeah. This is where is it fair to say though we're at the edge of the research there, and we're
Oh
still,
yeah, yeah. That's
yeah,
definitely more research based,
yeah.
but how cool, right? I
Yes.
was like, oh my God, I got so excited about it.
Because like in science, when you like expect a thing, right? So like a lot of times we'll see how something biologically like functions in this area, and then when we see something, we expect A and we get B, that's exciting, right? Because that's a new question to ask, a new avenue to learn something. So
I don't know that that's quite super new. It's at least a couple
it's new
years
to me.
since I've seen what?
It's new to me.
Oh, it's new to you, yeah. I know. But see, this is the stuff I did a project and I had discovered this and I was really excited about it. And I was telling my husband and he was like, I don't care about the Golgi apparatus. So, but the Golgi's really cool. And all of the little different cisterna in there and all the different I digress about the Golgi.
So would there be a thing that your husband would be excited about?
Of course, blood bank.
Melissa's husband, if you haven't picked it up by now, is like an avid blood banker, very passionate blood
Very,
banker. Yeah, and I think it's fair to say he's like deep in the theory and in the technical and
yeah, it's kind of
stuff
like
too.
we're super dorky with heme and he's
Yeah,
super dorky with blood bank, which
yeah.
sometimes it'll overlap, but
Does it overlap in this situation?
can overlap in this. So bringing in blood bank and
Yeah, yeah.
um, the von Willebrand factor molecule carries specifically the ABO proteins on its actual molecule. So it lands on the same different carbohydrate based proteins that you're going to find on your red cells, it'll land on those same proteins or similar proteins on von Willebrand's factor. Now, if you think about it, right? Let's drag in blood bank for a second. So
Yep.
you have group O, which is basically you have the H protein or the H antigen sitting on the surface.
Yeah.
And then if you have A, you have the A antigen in addition to that H antigen. If you have B, then you've got the B antigen in addition to the H. And if you've got AB, then you've got both A and B in addition to the H. Well, depending on where it's sitting on the von Willebrand's factor receptor, it can actually block the cleavage sites to break down von Wille, which results in a longer half-life of the molecule specifically for those blood groups. Not group O because it's only H that's blocking the site, but the other blood groups you'll notice have longer longer half-life, so a larger reference interval
So
for.
I just totally learned something there. So I remember back at my time in the clinical setting, learning that ABO groups correlated to different reference ranges for von Willebrand factor, but I didn't have like a causality link to that, right? So I didn't consider that you start with ultra large, it gets cut up, right? That how it's cut up is going to influence the antigen assay, right? So that's interesting.
Mhm.
I didn't think
Yeah,
about it like that.
and also just kind of breaking it down to get rid of it. It
Mm,
kind of blocks those sites too, the way that the blood, the ABO antigens kind of, I guess, land on
yeah,
that, which can give you longer or larger reference intervals for group A, B, and AB compared to O.
that's fascinating. That's really cool.
Yeah, so
Yeah,
that
I
was,
didn't know why. That's a good why.
yeah. You don't need to, I don't think people actually need to know the why. They just need to know that it's related, but there you go. Now you know the why.
Yeah, I always like knowing the why. Knowing the whys make memorization component like easier, you know?
Sometimes, yeah, that
Yeah.
helps certain students. It'll help them, yeah. But so really, von Wille is the level is dependent upon the patient's blood group.
Hmm.
Now, if you look at the most recent guidance that just came out, ISTH and a bunch of different other organizations together just put new guidelines out for diagnosing and taking care of von Wille patients. And one of the things is they're starting to consider, is 50% a cutoff? Is 30%? 30% is definitely a cutoff, but what is 50%? Like that could be a maybe, but some group O patients have, high 40s for their normal percentage of von Willebrand's. So there's still, it's kind of this, it's hard. And we'll
Hmm.
talk about why it's so hard to talk about the reference interval cutoffs when we actually get to von Willebrand's disease.
Mm.
But most places will go by blood group as your reference interval, and some places are starting to move away from that based off of the most recent guidance.
Interesting.
But it's still important for people to know that blood group does influence the reference interval for von Wille.
And is there so because of the variability there, and it's almost you kind of need the clinical picture too, right? Like especially with these borderline
Well,
cases.
so now we're digging into the weeds of the disease, Dave. So
I
sure. So
keep going in the weeds.
when you talk about the disease, in order to really get von Willebrand or to diagnose von Willebrand's disease, you should either have patient history or family history
Okay.
of bleeding. You
Yep.
don't want to have none, no history in anybody, and then order a von Willebrand screen, because what do you do if it's abnormal?
Yeah.
So you're going to diagnose them with von Wille if they've never had a bleed or easy bruising or anything.
This is where the shotgun approach to like test ordering can really backfire. It can put you in a bad spot. Yeah.
Well, and it's estimated that 1% of the world's population has borderline low levels normally.
Mm-hmm. Yep.
So
Yep.
are they disease or are they just normal?
Right. Right.
If
Right.
they're not, if they don't have any mucocutaneous bleeding,
Yeah. A lot of normal patient like reference ranges and stuff like that is pretty clear cut, and then other areas it's just not. There's a lot of nuance there. Um,
but we'll get more into that when we talk about von Wille disease.
okay, fair enough. I can live with that. Um, so yeah, von Willebrand factor. Do we cover everything you think for our entry level?
Yeah.
Good. Because I mean, we are talking about this from kind of from like an entry level competency MLS kind of perspective. Is that fair? Yeah.
Yeah. We'll touch the weeds sometimes, but we won't go too far.
I keep dragging us. All right. So in talking about von Willebrand factor, we talked a little bit about the platelet receptors
Yeah.
that might interact with von Willebrand factor. Is this a good segue to maybe start talking about platelets and their receptors? Think so?
Yeah.
Okay.
Yeah, because we've talked about almost everything with normal resting platelets except their receptors.
So I'm gonna be the dummy in this conversation, as everyone's probably noticed thus far. So I kind of think about platelet receptors. There's like the more functional, like sticky guys, and then there's the activate, make them mad kind of receptors. Is that like a oversimplification?
I don't know that any of them just make them sticky. That's usually an adhesion molecule.
Right. So like when I think of like 2B3A and its functionality, right? Those kinds of things. That's what I mean to say.
No, I wouldn't classify 2B3A as a sticker.
Okay. All right. So let's dig in here then.
Mm.
Where do we begin, right? So um, we talked about von Willebrand factor needing to be able to bind to collagen and platelets.
Mhm.
Is that to say platelets are incapable of binding to collagen without von Willebrand factor?
No, they can bind directly.
Okay.
Just like we were saying before, in high shear flow rates, because
Yep.
they're moving so quickly, you need something to connect them. And
Okay.
von Wille is that something.
Okay. So
So,
then let's say I get into a capillary space where blood flow is slower, or maybe, and it's there's there's less of these shear forces that we talked about. So what do platelets use to stick to collagen?
yeah, so there's the big collagen receptor is glycoprotein 6.
Okay.
That is like the key collagen receptor that's going to trigger activation. It's from the immunoglobulin gene family because it shares some of the same structural like domains in its gene as other immunoglobulin genes. But really, the when you think about glycoprotein 6, one of the most important things is it is responsible for upregulating our inside out activation. What? Inside out activation? You'll probably read that in your textbook or something. And it's really confusing if you think, what is inside out? Because if there's inside out, there's outside in.
Yes.
Right.
And
So,
we always think about outside in, right?
mhm.
And so let's
So
talk. Yep,
let's
yep,
talk about outside in first. So
yep.
outside in activation is basically you're binding to a receptor and you're sending a signal into the cell. So from the outside, you're sending in a signal and causing activation.
Hmm.
Make straightforward, right? That's
Yeah.
outside in.
Yep, yep.
Inside out is then you have things that are happening that actually send a signal out to a receptor and tell it to do something.
Which then prompts an out
Hmm.
in out out in.
Yep.
Okay, we've
So,
definitely gone down the rabbit hole now, right?
so inside out signaling. So let's talk about glycoprotein 6, right?
Yep.
So glycoprotein 6 is going to activate your platelet. So from something you're a platelet
Hmm.
and you have your glycoprotein 6 receptor and you bind to collagen with glycoprotein 6.
Hmm.
That sends a signal into the platelet to start activation,
Hmm.
right? And so one of the things that happens then is a signal is then sent out from that activation process to glycoprotein 1A, 2A. And now you're activating 1A, 2A. You're actually making it in its more active conformation so that now 1A, 2A, glycoprotein 1A, 2A, can also bind to collagen.
That's interesting.
So that's one of the major things. And then, of course, it'll do the same thing with 2B3A. 2B3A is like the big inside out. activating receptor, but 1A2A is also. So you need to have glycoprotein 6 activated, right? That's the major one, so that you can activate 1A2A. And really, all that does, having two collagen receptors, is give you a really good bind onto the endothelium. That's all it's going to do.
Yeah. And that kind of makes sense, like intuitively to me, right? Like from rock climbing, I'd like to have, right? The
As many
stability.
hands as possible.
Yeah.
I need more hands.
Yeah. Well, that's fascinating.
Mm-hmm.
Um, so um, so that's great. So now that's collagen, right? That basically covers collagen. Are we comfortable there? Good, good. And then we had started to talk about some other receptors. So uh I love saying 1B95. And I hated learning about it because it's really, really complicated how that all kind of comes together. But we had mentioned it when talking about von Willebrand factor, right? So von Willebrand factor has a site that binds to a platelet's 1B95, right?
Yep.
So are platelets just swimming around with 1B95, like just ready to go, or like
Yeah, so 1B95 is in its active conformation.
Mhm.
So 1B95 is confusing, like Dave said, because we call it 1B95. You could see 1B59, it doesn't really matter. 1B95 is the best way to put it. This way you can memorize the ratio of the molecules.
Yeah,
So
that's a good way to put it. Yep, yep.
yeah, so one, and some people even just drop the 5. They call it 1B9 because 5 is not important, because lack of 5 doesn't cause disease.
Right, and which is interesting. Yeah, yeah,
Lack of everything else causes disease,
yeah.
but lack of 5 doesn't. So some people drop the 5, but we'll include it. So 1B95, 1B alpha, 1B beta, 9 and 5. So 1B alpha and beta are actually two distinct proteins.
Mhm,
So you have 1B alpha, 1B beta. You have two of each. So two 1B alphas, two 1B betas, two nines, and one 5. And they're all non-covalently bound together.
mhm. Okay,
So 2, 2, 2, 1.
okay. And I take your point, right? So if you did the 1B59,
You just have to
then
remember 2, 2, 1, 2. But
yeah, and that's not as intuitive. Yeah, 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 yeah. Well, I'm glad I kind of burned it into my head as 1B95. It actually kind of, for me too, just kind of rolls off the tongue a little bit.
that's because we're used to saying that, though.
I guess so. Yeah, it's just I'm programmed already. That
Yeah.
makes sense. So yeah, so we have platelet receptor 1B95 binding to our von Willebrand factor, which is then bound to our collagen. And
Mm-hmm.
then cool. So how do we get uh is there so as this is where I get a little bit foggy, I guess. Is this already ready to go, or is there some kind of thing that happens to prompt
Ready
it?
to go.
Ready to go?
Sitting
Cool.
there ready. So you have, like I said, 1B, excuse me, alpha. And that specifically is responsible for helping tether von Wille and the platelet together.
Okay.
And then you have 1B beta. And that is really the portion that's responsible for sending a signal into the platelet for activation. So the 1B beta portion. And then you have 9 and 5, and they're really responsible for assembly of the 1B molecules. 9 being, of course, more important because we know lack of 9 causes disease.
Disease. Yeah.
Mm-hmm. So each piece plays a role in the process of activating the platelet. So yes, so that's a good point, is that platelets circulate with this receptor. Hey, here I am, right? It's like, here I am, baby. Right? One of those. Sorry, everybody, just had to listen to me sing. But the way that that's regulated is actually by von Willebrand's factor. So von Wille circulates kind of all balled up as a giant circular. It looks like a 3-year-old drew it, right? With all those like scribbles. That's what all molecular structures look like, right? They just look like a 3-year-old drew it. And what von Wille does is it actually hides its receptors for the platelet receptor 1B95. This way, once it binds onto collagen, von Willebrand's factor, it rolls out the carpet.
Mm-hmm.
And we call it rolling out the carpet because it is stretching out to expose those receptors.
Mm-hmm. Yep. And so that helps mitigate any spontaneous kind of because we don't want that happening when it's not supposed to, right?
Correct.
We actually have a disorder, right? TTP comes to mind, right? Ultra large, you get microthrombi, right? And not good.
Mm-hmm.
Okay, and then these are actually really good segues, right? So now Von Willie's being a good lead-in. So then Von Willie also had a receptor for platelet receptor 2B3A, right?
Mm-hmm.
So arguably, everything is important on these platelets. We're going to see that all of these pieces are like important, but I kind of put this one at the top of the list.
Yes.
Is that fair? Is that how you see it?
Yeah, so I think 6,
Mm-hmm.
1B95, and 2B3A are by far some of the most important receptors that the platelet has.
It's good that we're focusing on them.
Yes, we'll hit on the other ones too, but these are really the the more important ones. And actually, so I guess let's back up a hair, right?
Mm.
So with collagen, the 6, glycoprotein 6, if you want to test for functionality, right, platelet aggregation, you can use collagen as the agonist to test for that receptor.
Mm. Yep.
And then 1B95, excuse me, we would use ristocetin as the agonist for that receptor. And then now we're going to talk about 2B3A. And I mean, I guess you could really use anything because you're looking for aggregation. And if you can't aggregate, then none of your agonists will really work except for
Right.
ristocetin. That's a long story.
Right. Landsman's cough, cough. Yeah.
We'll get there. We'll get there. Not yet. But let's focus on 2B3A and then we
So,
can
so,
move on.
so 2B3A. So I'm going to be a little bit I just told the audience, I'm a little bit foggy on the details, but is 2B3A circulating, ready to go on our platelets? Okay, cool.
So remember we talked about this with the glycoprotein 6, how
Yep.
it's the major glycoprotein that's going to activate the platelet and then be responsible for inside out activation.
Yep.
So inside out activation of 1A, 2A, and 2B3A. So 2B3A is found, of course, on the platelet's membrane, but it's also found in the surface connected canicular system and on the alpha granule membranes. So it's everywhere
That's interesting.
in
Yeah.
the platelet. And so,
It's really important, right? I mean,
yes.
yeah.
Yep. Yeah, and it's one of our heterodimers, right? It's part of the integrin family. So it's a heterodimer, which means it's made up of 2 dissimilar proteins. So the 2B and the 3A, different proteins that make up this molecule. Like 1A, 2A is also an integrin, similar, so a heterodimer.
Mm-hmm.
And it's going to basically be activated. So it's found in its inactive or less active conformation. Once you activate it, you send that signal to the receptor becomes active.
Mm-hmm.
And then you can go through the process of aggregation because
Right.
that's our aggregation receptor.
Right. And then I had talked about fibrinogen plays a key role here, right? So without fibrinogen, there is no 2B3A interaction or less.
So way less. So fibrinogen is the major aggregation protein.
Okay.
And so it binds onto the different 2B3A receptors and allows the platelets to really bind together. Without fibrinogen, von Willebrand's factor, fibronectin, vitronectin can do it because they share the RGD domain.
Mm-hmm.
And when we say the RGD domain, we're actually just talking about the amino acids. It's arginine, glycine, and aspartate. That's our RGD domain. It's a particular sequence that you can find in the molecule. And so they share that same sequence. All of the von Willebrands, the fibrinogen, the fibronectin, vitronectin, they all share it. So they can all bind to the 2B3A, but it's really fibrinogen is the major.
Right, right. You're going to have severely decreased functionality in the absence, and for lots of reasons too, right? I mean, obviously, well, fibrinogen's important in other ways.
We'll
So
get there
yes,
too.
yeah. So 2B3A needs to be kind of turned on, right? This needs to be, and that makes sense to me because I feel like if you had 2B3A just circulating, like, you're going to thrombus, and yeah, it'll be bad for business.
Well, I imagine fibrinogen is not going to regulate itself the way
Right,
that von
right,
Wille does.
right.
So there has to be a regulator somewhere, and that's the 2B3A receptor itself.
Yep. Cool. So, where do we go from here now? Is it
Yeah. We've got other receptors.
right?
So most of the rest of the receptors are what we call the seven membrane or the seven transmembrane repeats because they have a particular structure where they traverse the membrane 7 times. So they have those hydrophobic portions of the receptor. And then you have your other portions. So you have anchoring domains, and then you have, of course, pieces sticking outside and pieces sticking internally, which is key because you have your receptors that can bind outside or cleave, depending on which agonist or which substance, the ligand that binds to it. Depending on the ligand, some cleave them and some just bind onto them.
Mm,
But
mm,
on the inside of our platelet, what's happening when you bind on the outside is that you're activating what we call our G protein pathways.
mhm. This gets confusing.
This is where we get into weeds, right?
Yeah.
So almost all of our seven traversing receptors that we're discussing, almost all of them have G proteins on the other side,
Mhm,
on the inside of the cell. Which G protein? That'll vary, and that gets way too in the weeds, right? I've
mm,
taken advanced cellular biology, and we don't even go that far into the weeds of each G protein pathway.
mhm,
But we call them G protein pathways because essentially, remember we talked about heterodimers for the integrin family, and I said they're two dissimilar proteins. We have heterotrimers. So now we have three dissimilar proteins, and we usually just designate them alpha, beta, gamma.
mm,
And so what happens is you have these heterotrimers sitting on the inside of that seven transmembrane receptor. And your three proteins are sitting there together, all bound with a GDP, right? So that's your guanosine diphosphate molecule. That's why we call it a G protein because of the guanosine. And then when you bind to the external portion of that receptor, you're basically going to send a signal in, and now you're going to have a GTP, so a triphosphate. And what
mhm.
happens is you're able to basically hydrolyze the GTP molecule, which allows you to have that kind of free phosphate, that radical phosphate molecule. And that phosphorylation, like that process, that hydrolyzation of removing that phosphate group gives the heterotrimer energy. And so what happens is the beta gamma portion separates from the alpha portion, and they go off and they activate downstream signals, and then they come back and they reassociate with GDP and the inside of that receptor.
Okay, so I'm a little bit dead inside listening to that. So,
Right? It's terrible. But like, that's really in the weeds.
yeah,
That is really in the weeds. So I think the important thing to know is that these receptors, the transmembrane receptors that traverse the membrane 7 times, they are G protein activators. They activate these G proteins that are going to go and activate normal physiological downstream systems.
right. And we see this in other cells, right? This is
Oh
like
yeah.
this is nature has taken cut and pasted this in a lot of different
Yep.
systems. So,
Yeah. So I think as long as you know that it's G proteins,
mhm.
there you
Yeah,
go. I don't know that anyone is ever going to want you to go into the weeds further than that. If they do, bless them.
yeah, right. Seriously.
That's a lot, you know? So these receptors that we're talking about then are like the thrombin receptors.
Yep.
And thrombin is actually one that cleaves its receptor. So once it cleaves a receptor, it's not going to reuse that receptor again.
And thrombin, I mean, thrombin is a cleaver, right?
Yeah,
Like
that's what it is.
that's yeah. So that makes sense.
That makes sense. Yeah.
So thrombin, other receptors. So I'm kind of like digging back into my platelet ag stuff I've done. The other one that comes to mind, ADP. Stop me if I'm like going ahead of the
So those are agonists you're
right.
talking about, right? So the agonist thrombin has two receptors that it can bind to.
Yep.
And then ADP also has two major receptors that it binds to. And I think we'll actually mention them,
Mhm.
P2Y1 and P2Y12. And the reason we mentioned P2Y12 is because there's an antiplatelet agent directed specifically against P2Y12 that we'll eventually get to.
Yep. Cool. And then epinephrine.
Mhm.
Epinephrine. So it's an adrenergic receptor.
Yeah. It's good. That one, yeah.
I can't words, right? And then quickly, so is it too early to talk about thromboxane and
No, we'll be getting
prostaglandin?
there shortly.
Okay. All right. So, and then we have a receptor for thromboxane, or we have two different receptors for thromboxane and our
Yep.
prostacyclin. Yep. And those are really cool molecules,
Mhm.
very similar molecules
Yep.
that have these kind of opposing roles in the platelet, right? So one's going to help regulate, and one's going to help. Well, both regulate, I guess. So one promotes and one suppresses.
Yeah. One will promote aggregation and one will suppress it.
Yep. Um, cool. So that's a lot of different receptors. So I'm deferring to you very, very much here, right? So how do we proceed? How do we talk about what the G proteins do inside the platelets? Is that the next part of the story, or so you
Sorry, I muted to cough and then I never unmuted myself. Yeah, so we can. So like I said, the different G proteins are going to do different things.
Mhm.
So we'll talk about one of the major things that they can do, and everybody's heard of this, right? The eicosanoid synthesis pathway. So essentially, your G proteins are going to activate phospholipase A2.
Mhm.
And that is going to basically take phosphatidylinositol, which is one of your membrane proteins, and it's going to make that into arachidonic acid. Now, the other name for one of the major arachidonic acids is basically the icosanoacetate. Nope, I said the word completely wrong. It's like I can't even say it. Never mind, I'm not even gonna try. I can say it, I just can't say it right now because I'm trying to. Icosanoid. So it's icoso something something. So it's got the word icoso in it, basically, is what I was trying to say. And
All right.
that's why we call it the icosanoid synthesis pathway, is because you make arachidonic acid.
Mhm.
And that's an icosanoid molecule. There we go. We're just gonna call it an icosanoid molecule. I can't say the word right now. Yes. So we get arachidonic acid, and people have probably heard of arachidonic acid.
Right, because this is an important the next step.
Mhm.
Well, I mean, everyone's going to have different levels of familiarity with things like aspirin, right?
Mhm.
So arachidonic acid will then be uh, functionally altered by COX, right? So this is the
Yep.
cyclooxygenase, I think, yeah. Um, and so that eventually leads
Mhm.
to, depending on where we are, right? So is this the platelet doing it, or is this the endothelium
Yep.
doing this, right? So if our platelet's doing it, this is going to lead to our thromboxane.
Yep.
Is that correct? Yeah. And thromboxane, well, we'll go, yeah, anyway. And um, if it's in the endothelial cell, we get our prostacyclin, right? Um, so, so aspirin's, this is maybe a detour, but aspirin's method of action is to suppress that enzyme, and
The
so just
cyclooxygenase enzyme.
yep. So inhibit COX, right, and then stop the production of thromboxane, which then decreases platelets' functionality and ability to activate. Right.
Mhm.
Um, so so then when our platelet makes thromboxane,
Yep.
this is fun too, right? It's going to excrete that, and then that can then interact with other surrounding platelets, right?
Mhm.
And so thromboxane is going to bind to its thromboxane receptors and then cause. So this is how platelets recruit other platelets, right? Is that a fair way to say it?
Yep.
So a really, really important pathway there.
Yeah. And it really all comes down to activating your platelet, comes down to mobilizing calcium from the dense tubular system.
Yeah.
And so in the end, thromboxane is going to mobilize the calcium from the dense tubular system, which activates the platelet.
Yep. Yep.
And prostacycline is not. It's going to
Right.
stop the calcium from exiting the dense tubular system.
Yep.
Really,
So
that's
there's
that's
this
what.
like tug of
Yeah.
war, right? Yep. So that's the most beautiful part of biology is when you see these systems and um I imagine the platelet as like the devil and the angel on the shoulder, and they're both telling different stories, right? And if you have more of the one, then you're gonna do that thing. Um,
And then
really,
you've got thromboxane in a little devil's outfit, and
yeah.
you've got
That's-
prostacycline in this little angel outfit.
yeah. Both telling the platelet, you should activate. No, don't do it, right? And then whoever's louder ends up winning that war. Um, Sorry, my dog's scratching at the door. All right, so where do we go from here now, right? So we've
Well,
covered a lot of the receptors. Yep.
we covered the major receptors that we need to discuss. There's other receptors, but again, weeds, right? We don't need to go into the weeds.
Right, right.
You can stay out. But all of the receptors are going to activate these downstream system pathways that eventually lead to calcium either being dumped from the dense tubular system or not. You'll see them, like if you look at diagrams in textbooks, you might see like the inositol triphosphate pathway and like how that activates, and more specific information about like the phospholipases. Weeds again, I think that's too far, so we're not going to go that far into it. I think what the next Dave's happy if you guys can't see him, if you're listening on the podcast. Dave started sweating when I started talking about that a little bit. He thought I
I
was going to
do.
go in.
I do. When Melissa talks about coag, I just start to perspire. Okay.
I think the next place we go is actually talking about what happens when you injure a vein, a venule, something.
Yeah. So when you disrupt the endothelial membrane, right? Or the endothelial. So we talked about endothelial cells, and we talked about how they're organized.
Mhm.
Um, so when there's some kind of injury there, and that's disrupted, collagen isn't exposed, right? That's kind of like the first thing that pops into my head. So then collagen exposure. This is where we get our glycoprotein 6, right, on our platelet interacting, or possibly von Willebrand factor.
Mhm.
Um, so that's kind of, I guess, what I have like in my head, right?
Yeah, yeah. And so that's adherence, right?
Yep.
Is platelet to collagen binding, whether it's direct platelet to collagen binding or platelet mediated by von Willebrand's factor. Either way, the platelet to collagen binding is considered adherence.
Okay.
And
So I have a platelet and he's stuck to the collagen. Game over, right? All done. Job's
we're
done.
done. I'm all set now. Yep.
No, that's not the end of the story. So what's the next step? Adherence is important, but then what follows?
Yeah. Then we have aggregation.
Hmm.
Right? And so that's platelet to platelet binding, which really is platelet to fibrinogen to platelet binding.
Right, right, right.
But we call it platelet to platelet binding
And
for.
that's our 2B3A and that interaction. Yeah. Cool. So then aggregation, right? And are we at the end of the platelet story, sort of, at least for this level, or
Yeah, I think we should back up a hair though and just talk about when we activate a platelet, right? When you send a signal in to activate the platelet. We talked about activating 2b3A as one of the things. But when you activate a platelet, other things happen, right? So you're first of all, you're going to cause shape change. So usually I'm this nice discoidy shape for a platelet, resting platelet. And then once I'm activated, I start having little pseudopods come out and the rest of the cytoplasm kind of retracts. So you get these definitely large pseudopods. And the point of the pseudopods is really to increase surface area, and the contraction of the cytoplasm helps with that. It also helps to shorten the surface connected connective system so that you can dump your alpha granule contents out faster. The dense granules don't care. They just go over to the side of the cytoplasm and throw their stuff right out into the world. So they don't use the surface connected connective system, but you shorten the SCCS by having that shape change. So shape change is one of the big things that happens. Of course, activation of TB3A is really important. The other really big thing that's important is basically taking your polar phospholipids and flipping them to being available on the outside of the platelet surface.
I can't believe I forgot to even talk about that. Like that's absolutely critical component to secondary hemostasis, right? Without that, we get no secondary hemostasis. So I'm glad you touched that. Cool.
Yeah, so I think those were the big things about activating a platelet. And that's whether you're activating for adherence or aggregation. It doesn't matter. When you activate a platelet, those are the things that happen.
Yeah, so like is it synonymous? Is it fair to say that it's synonymous when you say like shape change and like secretion? Like those things kind of like go hand in hand, right? Yeah.
Yeah, and that's the other thing that forgot to mention was granule secretion. Well, actually, I did mention that because
Yeah,
the
we touched. Yeah,
yeah,
yeah, we touched it a little bit. Yeah. Yeah, and the SCCS and that whole game. Um, cool. So, geez, I think we kind of did it on the platelet side of things. What do you think?
yeah, I think that's everything that we wanted to cover.
So I hope the audience kind of appreciates platelets as much as I appreciate platelets. I literally was a working hematologist for a while, and my real passion for it developed later on through study. And I never appreciated those little blue and purple dots that I saw every day on the scope. But cool. I think it's a good place for us to end, and we'll pick it back up at the next stage in the story of coagulation. So thank you to the audience. Thanks for hanging around and listen to us. Please reach out to us. Send us messages via email. We love to hear from you guys. Check us out on social media. Subscribe anywhere you see a subscribe button in differential discussions. Just click that. And yeah,
Yeah, so thanks for listening.
thanks for your time.